I, Dr. Anup Kumar, I will discuss today asthma in children. Definition: it is chronic inflammatory disorder of airways. There is increased airway hyperresponsiveness, wide speed but variable bronchoconstriction, inflammation of the bronchial valves, and increased mucus secretion. It is often reversible to bronchodilator therapy. Chronic inflammatory disorder of airway that causes recurrent episodes of wheezing, breathlessness, chest tightness, cough, particularly at night and early morning. Prevalence varies between different population, 0 to 30%. Increased prevalence is there in last 2 decades due to urbanization and pollution. It is more common in children. Mortality and morbidity also increased in last 2 to 3 decades. Etiology: a combination of age, environmental factors, biological factors, and genetic factors are responsible for bronchial asthma. Environmental factors are allergens, infections, microbes, pollutants, stress. Lower age group: biological and genetic factors like immune factor, lung factors. There is immune and adaptive immune development. They call atopy. Some children are atopic, having atopic symptom like atopic rhinitis, atopic dermatitis. And there is a recurrent lower airway injury by respiratory viral infections, aeroallergens. There is a pollutants toxicants, and also there is aberrant repair by remodeling due to persistent inflammation, remodeling, airway growth and differentiation leads to asthma in children. Etiology: environmental viruses are RSV, rhinovirus, influenza virus, parainfluenza virus, adenovirus. Aeroallergens like indoor, home allergens, pollen, mites, dust, etc. Environmental: tobacco smoke, air pollutants, cool dry air, strong odors can trigger bronchoconstriction when airways are irritated. Eliminating of offending allergens can lead to a resolution of symptoms and sometimes asthma. Triggers are exercise, pollen, grains, bugs in home, and these chemical fumes, cold air, fungal spores, dust, smoke, strong odors, pollution, anger, stress, pets. Drugs are NSAID, aspirin, beta blockers are the asthma trigger. Asthma triggers are already explained, where this one 11 number is comorbid conditions like rhinitis, sinusitis, gastroesophageal reflux. Pathophysiology: asthma, whatever the severity, is a chronic inflammatory disorder of the airway. There is three component: smooth muscle spasm, airway edema, mucus plug. Airway inflammation in asthma is a direct response of the immune response to trigger a cascade of immunological events that includes inflammatory cells and mediators, an immune-mediated process that leads to inflammatory changes in the airway, including eosinophil recruitment and airway edema. Asthma, you can see in this picture, there is a lumen is wide in normal, but it becomes very narrow in abnormal. It is caused by acute and chronic inflammation, leads to structural changes and widening of the muscle layer due to airway remodeling. Histological finding: normal airway, you already know. Histological finding: inflamed airway. There is eosinophils, mucus is there, and there is mucous glands, widened epithelium is there. Edema with widened spaces in smooth muscle cells there. Then also plasma leakage. Why asthma is common in children? Because airway is already narrow in infant or children. If edema, it causes all further narrowing. There are inducers, allergens, chemical sensitizers, air pollutants, virus infections, leads to inflammation, causes airway hyperresponsiveness and leads to airflow limitation by triggers like allergens, exercise, cold air, SO2 particulates causing symptoms. Early and late asthmatic response following allergen challenge is shown in this graph. Asthma clinical features: recurrent cough, cold, wheezing and breathlessness, seasonal variation, exertional nocturnal atopy, feeling of tightness in the chest, exercise intolerance, family history of asthma. On physical examination, there is tachypnea, tachycardia, chest and drying with audible wheeze, cyanosis, ultrasensorium. On spirometry, there is PEFR, FEV1 abnormalities, SpO2 may be low, pulsus paradoxus may be present. On chest, there may be rhonchi. You can detect sinusitis. Acute asthma differential diagnoses are bronchiolitis, tuberculosis, immune deficiency, cystic fibrosis, ciliary dyskinesia, foreign body aspiration, hypersensitivity pneumonia, gastroesophageal reflux, congenital malformation, recurrent aspiration. Diagnosis keys clinical: cough with or without wheeze, recurrent, nocturnal, exertional, with atopy. On pulmonary function test, there is reversibility of obstruction. PEFR and FEV1 is decreased. Chest X-ray normal or maybe hyperinflammation and bronchial coughing. Allergy test, for example, skin test, rash test have limited usefulness. Blood IgE may be read in children with atopic asthma but cannot be used as diagnostic test. Role of skin test to identify sensitivity of different antigen and desensitization is limited. Desensitization by introducing a small amount of allergen in the child is known as immunotherapy. Clue to alternative diagnosis in wheezy children: symptoms present from birth or perinatal period, history of choking during fits, excessive vomiting or causating, severe upper respiratory tract infection, persistent bad cough, family history of unusual chest disease. Clue to alternative diagnosis in wheezy children: failure to thrive, unexpected clinical finding, focal signs, chest, abnormal voice, cry, dysphagia, respiratory stridor, congenital heart disease, recurrent infections, malabsorptions. Investigation when alternative diagnosis is expected: chest X-ray, hemogram, Mantoux test, sweat test, test for HIV, bronchoscopy, electron microscopy for primary ciliary dyskinesia, GER, absolute eosinophil count, barium swallow, mutations for CF, immunodeficiency test, chest CT scan, saccharine equivalent test, spirometry and bronchodilator response. Etiology: there is hyperinflation and bronchial coughing. Laboratory testing: there is spirometry, airflow limitation is there, low FEV1, FEV1 by FEVC ratio is less than 0.8. Bronchodilator response is there to inhaled beta agonist. Improvement in FEV1 is more than 12% or more than 200 ml. Exercise challenge: worsening in FEV1 more than 50%. Daily peak flow or FEV1 monitoring day to day and AM to PM variation more than 20%. Natural history onset can occur at any age, but children and young adults are commonly affected age groups. 5 to 10% of children with mild to asthma go on to develop severe asthma later in life. Although asthma cannot be cured, clinical episode can largely be prevented, controlled by proper management. Allergic rhinitis and skin allergy may coexist with or precede the onset of asthma. Variability in the clinical course, persistence in some individuals and progression in others. Two is the persistent atopy associated asthma. Begins in early preschool years, associated with atopy in early preschool years. Clinical atopic dermatitis, allergic rhinitis, food allergy in infancy. Biological, the increased IgE, early inhalant allergen sensitization, increased blood eosinophils. Highest risk for persistent into later childhood and adulthood. There is lung function abnormalities. Those with later onset symptoms or with later onset of allergen sensitization are less likely to experience airflow limitation in childhood. Non-atopic wheezing. Wheezing and coughing begins in early life, often with respiratory syncytial virus infection. Resolves in late childhood without increased risk of persistent asthma. Associated with bronchial responsiveness. Asthma with declining lung function. Children with asthma with progressive increase in airflow limitation. Associated with hyperinflation in childhood, male gender. Late onset asthma in females, associated with obesity and early onset puberty, around 8 to 13 years of age. Occupational types asthma in children. Asthma associated with occupational type exposure, like endotoxin exposure in children, raised in forms. Clinical features and evaluation. Symptoms. Most common chronic symptoms: intermittent dry coughing, respiratory wheezing. Older children, shortness of breath and chest tightness. Younger children, intermittent non-focal chest pain. Symptoms worse at night. And daytime symptoms linked with physical activity or play. There may be self-imposition of limitation of physical activities. Genital fatigue. Difficulty keeping up with peers in physical activities. We have to take history for triggers, and we also already discussed environmental history, also essential for optimal asthma management. Treatment is only symptomatic. Improvement with treatment also supports diagnosis of asthma. Clinical clue to alternative diagnosis in wheezy children. Symptom present from birth or perinatal lung problems. Cystic fibrosis, chronic lung disease of prematurity, ciliary dyskinesia, developmental anomaly. Family history of unusual chest disease. Occurs in chest fibrosis, neuromuscular disorder. Severe upper respiratory tract disease. Defect of host defense, ciliary dyskinesia. Symptom and signs: persistent moist cough, cystic fibrosis, bronchitis, protracted bronchitis, recurrent aspiration, host defense disorder like ciliary dyskinesia, excessive vomiting, gastroesophageal reflux, aspiration, ventilations with light redness and peripheral tingling, hyperventilation and panic attacks. Differential diagnosis on symptom: respiratory tracheal laryngeal disorders, abnormal voice or cry, laryngeal problems, vocal signs in chest, developmental anomaly, finger clubbing, cystic fibrosis, bronchitis, failure to thrive, cystic fibrosis, GERD, focal or persistent radiological changes, developmental anomaly, cystic fibrosis, post-infective disorder, recurrent aspiration, inhaled foreign body, bronchiectasis, tuberculosis. Breathlessness occurs, it varies between mild, moderate to severe. In severe occurs in rest, and in severe only child can say word. In alertness also decrease in moderate and severe, child become agitated and drowsy. Respiratory rate is increased in severe. The use of accessory muscles also is there. Breathing also increased in severe. Pulse rate is high. Pulsar paradoxus is present. Classification asthma based on severity: intermittent and persistent. In persistent, there is three types: mild, moderate, and severe. It depends upon the symptoms, how much impairment is there. Daytime symptoms, nighttime awakenings, short-acting beta agonist use for symptoms, interference with normal activity. There is severe limitation of activity in severe bronchial asthma, and daytime symptoms occur throughout this day. Nighttime symptoms also more in severe, and we have to use short-acting beta agonist in severe several times per day. Classification of asthma severity based on FEV1 is around more than 80%, intermittent mild, moderate is 60 to 80%, severe is less than 60%. FEV1 by FVC is group 5 to 11 years is more than 85%, in mild more than 80%, in moderate 75 to 80, severe less than 75%. At more than 12 years, it is normal in intermittent mild. In moderate and severe persistent asthma, it is reached to 5% and more than 5%. Exacerbation requiring systemic steroids is a mild, moderate, and severe. There may be more than two exacerbations in 6 months requiring systemic corticosteroids, or more than 4 wheezing episodes lasting more than 1 day. A risk factor for persistent asthma is there. And it is 0 to 1 intermittent, mild, more than 2 per year, and moderate, more than 2 per year. Results of investigation suggest alternative diagnosis, treat accordingly. No diagnosis, trial of anti-asthma treatment, bronchodilators and steroids, see response, good response, follow as asthma, no response, investigate for alternative diagnosis. Management bronchial asthma cannot be cured but can be controlled. Goal of therapy are to maintain near normal pulmonary function, maintain near normal physical activity, prevent night-time cough or wheezing with minimal chronic symptoms, prevent recurrences, avoid adverse effects of therapy. Effective long-term management of asthma involves 3 major areas: identification, elimination of exacerbation factors like triggers, we have to avoid it; pharmacological therapy, education of patients and parents about nature of disease, and steps to avoid acute exacerbation. Treatment principles of asthma: avoidance of triggers, bronchodilators for immediate relief in symptoms like salbutamol, tabicillin; anti-inflammatory agents for long-term control of asthma like inhaled corticosteroid, Cromwell, LTRA. Aerosol treatment is more effective. All patients may not have severe disease. General advice: allergen avoidance should be done. Removal of either of woolen bedding, wrapping of mattress in plastic, cleaning of carpets and furniture, no pets in house if child is allergic to them, passive smoking should be avoided. Drugs, relievers and controllers. For treatment of bronchospasm and to relieve acute attacks, relievers are used. Controllers are for long-term control of inflammation to prevent further attacks. Controllers are inhaled corticosteroids, Comorbid sodium, long-acting inhaled beta-2 agonists, and oral are leukotriene antagonists like montelukast, theophylline slow release, and oral prednisolone. Pharmacotherapy, we have to assess severity of the child illness and select medication according to severity of bronchial asthma, and we have to select devices accordingly, and we have to follow up the child regularly for monitoring. We have to follow a step up or step down therapy for bronchial asthma. We can start based on the symptoms of the child. Start from step 1. If there is no control, we can step up to step 2 or step 3 or step 4. Depends upon the symptom and how much severity of and persistence of symptom is there. In step 1, if you are having mild intermittent bronchial asthma, we usually need best inhaled beta agonists. Step 2, mild persistent bronchial asthma, we have to give a low dose inhaled steroid to a continuous prevention or mandatory Lucast. Step 3, moderate persistent symptom bronchial asthma, we have to give continuous prophylaxis with medium dose inhaled corticosteroid or low dose inhaled steroid plus long acting bronchodilator. Step 4, in severe persistent bronchial asthma, high dose inhaled steroid plus long acting bronchodilator is given. Oral steroid can be also used. Stepping down treatment when asthma is well controlled for around 3 months, and then we have to step down. Non-pharmacological strategy interventions. A smoking cessation advice, allergen avoidance, avoid drugs probably triggering asthma. Some common triggers like exercise, laughter should not be avoided. Inhaled medication deliveries. Children less than 4-year-old, meter dose inhaler with a spacer with face mask should be used. Children more than 4-year-old, MDI with a spacer preferred as shown in this picture. Children more than 12-year-old, MDI used directly in the mouth, but use of a spacer improves lung drug deposition. Acute severe asthma. Acute severe episode of asthma due to severe airflow obstruction which is refractory to the usually effective bronchodilator therapy. Red flag signs. Too breathless to talk, too breathless to feed, respiration more than 50 per minute, pulse more than 140 per minute, poor volume, excessive diaphoresis. Life-threatening features: cyanosis, silent chest, fever, respiratory effort, fatigue or exhaustion, agitation, reduced level of consciousness. In acute severe asthma, we should give oxygen. If required, intubation or mechanical ventilation in pediatric ICU. We should start with salmetamol inhaled, continuous nebulization. If symptom is persisting, then we can give ipratropium bromide inhalation every 20 minutes up to 3 doses, then 4 to 6 hourly. Hydrocortisone 10 mg per kg IV is given, followed by maintenance, switch to oral if stable. Despite that, if a symptom is persisting or child is not improving, then we give subcutaneous terbutaline followed by terbutaline IV infusion. Despite that, if child is not improving, then we can use magnesium 50 mg per kg per dose, which can be repeated once or twice after 4 to 6 hours. If despite that no response, theophylline loading dose of 5 to 7 mg per kg followed by infusion should be given. If despite that there is no improvement, then child may require mechanical ventilation and should be shifted to pediatric ICU. Treatment of comorbid conditions: allergic rhinitis, sinusitis, intranasal steroid spray, oral antihistaminics, gastroesophageal reflux. We have to give anti-reflux treatment, and oral theophylline should be avoided. Thanks.